All right, everyone. So, welcome to this interview. So, I've got this man here, David. He's been pretty vocal in the GP space in particular for many, many years. David and I have probably known each other for a while now, so we kind of catch up briefly in our busy schedules. But I think now we're sort of crossing paths again with this new kind of buzzword that's happening around AI and what he's doing and what we're doing. And we're still looking for synergies. But I thought I'd bring him in today just to have a chat to allied health, business owners in particular, or those who want to start up. From an accounting perspective, what needs to be done from a compliance, particularly where there was a lot of talk and issues, probably still issues in the market around sham contracting and how you should address that as a startup. And then we're going to talk about the future of this side of uh, the spectrum around running an allied health business in terms of accounting, streamlining processes, and how AI will impact that, and how David sort of will predict the future of this playing out, which has been pretty good in the past at fortune telling. So, I'm going to let you introduce yourself, David, and then we'll continue.
All right, Barry, thanks very much for the opportunity to talk uh, to your viewers. So, just firstly, I'm David Dahm. I'm a medical and healthcare accountant. I've been operating nationally for 33 years and dealing with some fairly complex environments. People say, oh, specialists are complex. And with no disrespect to them, but general practice is probably the most complex area, and I tend to like to work in complex areas because you're working with multidisciplinary teams. There's multiple factors from mental health to physical disability issues, social and environmental issues, OTs, allied health people like yourself. I do come from a medical family of specialists, and I have a whole lot of allied health people. In fact, I've got a daughter studying physiotherapy as we speak, and works in a physiotherapy practice and have physiotherapy clients as much as I have medical clients and GP clients. And the issues that people are struggling with is there's been a lot of what I call people are copying without really thinking everybody else's business models, because they're saying they're going from 5x to 10x. And you know what? They see these big glossy brochures and beautiful people and signage, and everybody goes, oh, this is the way we must run things. And that's great, but they forgot to run it past their lawyer or past their accountant to see, well, hang on, do these all tick the boxes? And specifically, Barry, I guess what you're referring to was this whole concern about, well, hang on, am I an employee? Am I a contractor? Or am I actually like a tenant doctor? What am I? How do I identify myself? Am I a trans entity? I'm a bit of here, I'm a bit of both. And the reality is, in law and tax, and this is what's caught up with everybody, and particularly in general practices where you've seen this, and this has had a huge uh, blow-on effect to everyone, and so nobody's immune, particularly allied health and specialists, where GPs might have negotiated some temporary exemptions with lots of conditions attached, which is probably worse than being told to do it properly or just get out of the game. And what's really happened is they've gone and done audits, and they've gone and looked at people's bank accounts, and they've gone and looked at people's contracts, and they've gone and looked at their signage. They're doing Google site reviews. I mean, it's extraordinary because I've been involved in these audits, and I'm going, boy, and then they go and interview all the practitioners and say, well, who are you and how do you identify yourself? And your letterhead says one thing, but you do something else. Oh, by the way, that practice manager's basically using a practice's email address, which is not you, but you call yourself the practice. Are you a practice? What are you? Are you an employee of the practice? Are you a sole trader who contracts into the practice, and the practice then on-sells those services to to the public, to the general market? Or are you really one of those traditional shared office arrangements where you have your own business with your own letterhead, with your own website, and you're advertising with your own Google reviews and everything? So when things go wrong, it affects your name, nobody else's, and you're a sole trader where you are called a tenant doctor, where you're just sharing what are called back office services. And back office services could be a range of things. They can be physical premises, it could be staff, and it can be software, or a combination of all of it or some of it. But the reality is, you're the one who's holding your shingle out there, and you're saying, I'm on my own. And yes, I have some other people backing up me. And yes, you can have team care arrangements. But guess what? The buck falls on me. It doesn't fall on my employer, because I'm an employee. It doesn't fall on the head contractor because I'm just a subcontractor and they get all the money first. I don't get the money first. And this is how, these are what I call distinguishing factors that the courts have found, particularly in recent years. And this is what has been established in the High Court only in 2023. And this is affecting all allied health, medical and specialists. So nobody's immune to this. No matter how much of a caregiver you are and how wonderfully honest you think you are, that doesn't matter in a court of law. What they're asking is substance over form, right? What is your business model? How do you identify yourself, sole trader, employee, or tenant, practitioner, or doctor? I use that word because we've had to trademark that word in order for the tax office to recognize that when we talk about it, we mean a specific thing, and we can talk about that later, what we mean by that, but it's an evidence-based structure and arrangement and business model that ensures that there's symmetry of tax and accounting and business information versus everybody else, where everybody else is doing pretty much, it's a bit of this and a bit of that. For the Indian practitioners out there, is like a masala. It's just a mix of everything. It's not clear. So the whole thing that everybody has to consider moving forward, you need clarity, right? I don't really care what software you have. You just got to be clarity about your business model first, and that you're the one who's taking 100% responsibility, not partial responsibility, not joint responsibility, when you step out there and call yourself a physiotherapist. So I guess that sort of segues into sort of like, what is the future of physiotherapy look like? And that's sort of, and it's not just physiotherapy, it's all medical and allied health, is that everybody wants to be a solopreneur. Nobody wants to be told how to suck eggs, how to set fees. They want to work their idea, work their own hours. We call it what's called a lifestyle workforce. We want to be able to say no. We don't like to be told I'm an employee or I'm a contractor and I have to build this or do that. That's where the modern workforce has moved towards. And that's why you see highly educated, highly talented practitioners sitting there saying, I'm going to carry my own personal goodwill. I'm not going to share that or help somebody else build a business. I am the business and I want to be seen, and I am ultimately responsible. And therefore I take that responsibility, but I also enjoy the freedom, the flexibility that gives. And I'm accountable to myself. And then everybody underneath me, I will outsource, whether it's IT, whether it's premises, whether it's staff, to maybe locations where I will co-locate on a physiotherapy complex, for argument's sake, where multiple sole trader physiotherapists are being co-located, and they're being presented a bit like Westfield, and how Westfield's got Coles and it's got Woolworths. They've got competing practices because they're technically the practice. It's not Westfield that's selling the tomatoes. It's actually these individual businesses, the supermarkets that are doing it. And funnily enough, that's actually going back to the future. That's how practices are then set up, based on tax law, case law, medico-legal reasons. For medico-legal reasons, we're going back to the future. And now with technology, it's now becoming easier and cheaper to do that. And therefore, you've got a lot more negotiating room to do what you want to do, and flexibility that you probably didn't have, and you'd be tax compliant. You wouldn't have to worry about being deemed like an employee and having all these other problems with super, or finding you something with GST that you were claiming as a refund, you have to pay it all back. All these sorts of things go away if you can clearly identify who you are, what your business model is, and how you intend to scale yourself or others with you. Just be really clear. Are you the person being the gold miner, or you're the person who's selling pots and pans to the gold miners? And once that clarity is clear, it's really easy to move forward in terms of what ticks the right boxes for you moving forward.
That's very interesting insights there. So, I mean, a lot of the business coaches are saying, physio, you should hire full-time employees because then you can manage their performance, control their hours, etc. But then there's this other model, right? That's always been there and emerging again, I think, around, the advent of technology. Like, how do you manage these things around having a team around you and, managing their performance without sham contracting or etc.
Well, it gets to that point there. You've got to first be clear about what are you in the business of doing, providing administrative services, or are you providing physiotherapy services or allied health services? It's really as simple as that. And until you get and understand that, you speak to an advisor and somebody can explain it and articulate it back to you, that there is basically two distinct models. And I did have the joys of explaining that to the Federal Tax Office when they tapped me on my shoulder back in 2016 when I made a comment about that a big listed company that's called Primary Healthcare is no longer in business on exactly this point. They were being taken to task on exactly that point. They were not clear. All right, that's $1 billion company. So it doesn't matter how wonderful and good looking your accountant is. You have to understand the basic concept. Are you an administration business? And then if you're an administration business, you can have multiple sole traders co-located, and you can charge a service fee, 70/50 or 70/30 plus GST, whatever. And that's simple. And that's not sham contracting, right? And you then can have a proper agreement that can be signed off. We do a lot of that sort of work. And it's clear as crystal. The other type, which is the other extreme, which is called the employer-employee model, right? So the subcontractor model sits in the middle. You got the employer-employee where, they'll tell you, yep, you got to jump, how high, but you get annual leave and sick leave. And some people like that model, by the way. They like the structure, and particularly maybe if you're starting out and you're young, you like to be employed and under that. Yeah. But what happens is as you progress in your careers, everybody wants
I want to do that anymore.
Yeah, I don't want to be sitting there. I want to be working for me. I don't want to work for the other person. Yeah. And I'm prepared to cash out and take a higher percentage. I don't want my super going to me when I can pay off my home loan. And get the super, because you don't have to put super in if you don't want to put super in as a self-employed person. But there are financial benefits and rewards, a higher percentage, more positive cash flow, I guess more tax deductions legally speaking than being an employee. I don't hate saying all that. I'm not promoting tax evasion. I'm just saying you have more choices. That's all.
And you're building like equity, aren't you? Like
brand equity. Yeah.
Brand equity. So and I think you're drumming down that point. It's people are, a bit confused about that idea. They think it's more stable, to be an employee because of these laws that protect them. Do you think that's actually the case in a primary?
I mean,
in
look,
this industry?
Yeah, well, medico-legally, I'm not a lawyer. I'm not allowed to be one, but my lawyer friends tell me all the time that, if employer-employee, you are more protected because if you do stuff up, the employer does cop it and it falls to supervision. But it's like everything, once you start walking the tightrope yourself, you know how to do it yourself. You don't need to have so much help. And look, relatively speaking, in allied health compared to medical, the medico-legal risks are a lot lower. And it's not as risky maybe as some of the other professions there, like neurosurgery or something else. So I think and look, allied health makes bank. It pays exceptionally well. I think a lot of people underestimate how well it pays. Sometimes it pays better than general practice, to be quite honest, from what I've seen. And those that are creative and create sub niches and stuff like that can do exceptionally well and are highly sought after. So I think, look, most people will be an employee initially for a few years, get a bit more comfortable or returning back to work. But ultimately, there's this urge to make a bit more money, be a bit more tax efficient and effective, have a bit more freedom and flexibility. People do sit there and start thinking, is the grass greener on the other side? And maybe I'll give that a crack.
So there's this theory, like I've seen before in Allied, where you need 3 full-time practitioners to get your first receptionist full-time.
Oh, yeah.
Can you debunk that, or is that true? And is that a profitable way of doing things? So obviously you start off solo, as we talked about, and you build up from the back end, from what you see.
Yeah. Look,
What's your brutally honest view about that? Is that true? Is that...
Yeah, look, there is an element of truth depending on what your model is. I don't know if you can do telephysiotherapy, but you can just do things online like we're doing here. But the reality is, if you have to employ somebody, that's a fixed cost. That's a break-even cost. If you employ somebody, now you got to pay rent. Okay, so then you've got an issue, right? So you got another fixed cost, and inherently, like all businesses, you'll have a particular fixed cost and it doesn't matter how many patients you see, you're not going to make a buck until you cover your fixed costs for the rent and for the wages. And, to make bank, and that's going to vary, per full-time equivalent practitioner. And that might vary between, depending on how sophisticated your back end is or not sophisticated, could vary between, let's say, $5,000 maybe $9,000 per full-time equivalent practitioner to make bank. right? And it's not a variable cost. You can't just say, well, I'm not here today. Oh, I'm not going to pay you 3 hours leave, or you're apart. You don't pay you don't pay your landlord by the hour or by the patient. So therefore, yes, that's a real thing. Now, what is that number? Look, in the past, you'd probably say you could get away with maybe one or two, but those numbers are growing as you've suggested, only because the rent's high. And look, physiotherapy is capital intensive. You need equipment. Okay, so you're going to have to get into some cost sharing arrangement, and the more you can actually share the costs amongst multiple providers in solid, at one location, look, that fixed cost will drop dramatically. If there's one accountant acting for the group, it's a service entity, you're not paying, and there might be 5 practitioners, you're not paying for 5 accountants now. You're now only paying for one. So that's an example of how those costs drop. And that's why working smarter, not harder, and having what's called back office shared arrangements, which is what we call administration arrangements, is probably the most flexible and viable way to move forward. And obviously, the more you have there, the lower that cost is, and the more profitable you are. And so long as you've got carefully worded agreements and business models, yeah, it is certainly the way forward. And that's certainly, we've seen that in general practice and physiotherapy across Australia. That works quite well. The other issue is, the feminisation of the workforce, and I don't mean to, that's a big issue. And I remember the male practitioners, I'm always sort of, working hard and I do full time. Well, I think those days are gone, right? And even the males want part time because, as one male practitioner said to me the other day, well, I'll have what she's having, and they've got an ability to say no. I'll say no, and I'll finish at 3. And there's a lot more shared responsibilities at the home and raising family as well. So, when you're having part-time practitioners, it's great, and that work life great, but the compliance is more riskier because, communication issues, handover issues. How does that all work? And only with technology can you ensure there's some sort of continuity of communication. And you have to design your business models to do that well. And technology has been great for doing that, and stuff that I hear you guys are doing, becomes quite critical. All right. So if you've got the right tools, sometimes you don't need that staff member if you've got the right. I actually am looking at agentic tools and stuff that we're rolling out in practices in our own, and that's another level. That's the next version, where it does those things for you, right, in the background. So you watch this space, and it's happening very fast. Within 12 months, they'll become normalized, a bit like AI is becoming normalized now, and that was sort of hit us like a bolt from the blue 12 months, and it's rapid. So I think, that break-even cost that you talked about, that's dropping.
Fantastic.
Phone line screening, all that stuff, the
Yeah,
stuff
well
that,
done. Yeah, yep.
it's there. So I think really that's where we're headed, and that will be based on the innovators that are out there looking at these workflows and going, how else can we do it smarter and quicker?
So, agentic, what are you working on, if you're allowed to say? Give a sneak peek. Or what problem are you solving with it, maybe? And what?
Okay. Yeah, look, agentic, well, I'm not sure if people know what agentic means. Look, it basically means having little micro robots doing all the tasks that you don't like doing, but are still very important. Okay. And so even just internally in our own practice, it's just setting up new staff and just having checklists that ask them and follow questions and have you watch this video. It's talking to not one software program. And I think this is where software stacks are really critical. I'm sorry, I'm not a big fan of the whole Microsoft closed environment or even the Apple closed environment, so I hope I haven't offended anyone. But outside of that, so you'll see a lot of programs called SaaS, software as a service providers. And a lot of these providers, do some really useful stuff. Xero is probably an example from
Yeah.
a bookkeeping and accounting is an example of that. And what you're actually able to do is suck data out of that and then put it into another program. It might be your appointment or your billing program, or put the staffing hours in there, and you might have a different staffing module. And what Agentic's about, it's basically opening up all these different little apps, for the one of a better word, and getting them to talk to each other. And instead of you doing it manually, you can program it, you can prompt it, and it will actually do it for you. And so, well, could you calculate the pays or the percentages that that practitioner has seen, so we can calculate a service fee. So that's kind of what we're talking about.
It's
Yes.
available in the market yet, or is it still under?
Yeah. So what most organisations are doing now, the larger ones, if they've got dev teams, we have DevOps teams, and they're doing it internally for their own processes.
Right.
And then what you're seeing is, look, software programmers are dead. Whatever they've learned, they don't have to code anymore. they used to be AI coders. Well, what's replacing the AI coder now is these agentic coders, where you're basically looking at prompt engineering tasks that people find repetitive and all that. And there was even talk, I think it was Microsoft said, look, SaaS is dead. The
Yeah,
CEO
yeah,
of the thing.
definitely.
So, and that's I can look. I'm not sure if I'd go that far, but I can tell you, yeah, I can see why. When you now open up a program, a lot of stuff would just happen in the background by you just giving a voice command, and it would intuitively understand what to do next. And you do more sign-offs than actually going through all the steps, and it would just remember kind of what you do each time or each month. And I think this is kind of where this becomes quite empowering, and it makes your work more enjoyable, so you're focusing on what are called key issues. You'll still have AI is basically a tool that I see as a tool that just tells you and analyzes information for you, that you still got to make the decision, whereas agentic does stuff, and it will do more of the simplified tasks and the routine tasks. It won't do complex stuff. You won't be replaced. You will just find that you work in this funny augmented reality, that all the information you need at that point, your clinical records, the patient information, and you can be talking to your patient directly, but you'll have a real live feed. And as you speak, things will be happening and be done for you while you're talking, saying, oh, look, I need to find out that test result, and that would just happen. So I see that world definitely coming. Um, and we won't have mobile phones. We'll just have some sort of, camera thing like this Ray-Ban camera thing, and you'll be able to just look through your camera and actually be able to prompt you, by blinking or otherwise, for these sorts of records to open up. I mean, that's being very futuristic, but people thought mobile phones were crazy at the time, and guess what happened?
Mm.
But that's easily happening. I could see that happening in even next 10 years, easily, that type of technology being rolled out.
Right.
Um,
So, yeah. So, what are your tips for practice owners? Should they kind of go shopping? Is there a checklist?
hmm,
So you've got two types, right? You've got the ones that want to start a clinic that open
yes,
back, it's blank. And there's other ones, as you know, that have zero, that's probably not integrated into their software. They do
yeah,
pieces on spreadsheets. They always do the pays wrong, or they hate doing the BAS. A bunch of those issues every month.
yeah.
Like,
Oh, this is a tough question. I mean, I wouldn't ditch the old just for the new, for the sake of it, and say, well, I'm going to start Greensfield, because you don't have enough experience. None of us do, including me. I mean, but we need to start from somewhere. Look, my best encouragement is people join forces. Maybe talk about, well, hang on, what's our vision? What's our business model? Should we come together and have and share the back end of the office? So then if we need to do this sort of technology and all that, it's going to be easier to deal with organizations to do that, because you can have a great front end silo app solution, but if it doesn't talk to the back end, it will fail. You can't sort of enforce somebody's back end on somebody unless there is some sort of, because I think everybody will be moving to shared model, which is called basically consumption apps. So it's just user pay. It's a bit like, look, I'm sorry, I have a car, but I use Uber. My car unfortunately doesn't, it's just easier. I just don't have to park. I don't have to worry about where I'm getting picked up or dropped off. It just happens. And I think what we're going to see is practices will be basically, well, service entities that support these sorts of practice environments are going to do the consolidation, the heavy lifting from augmenting the IT, the marketing, and doing that all in the back end for the practitioners. So the practitioners come in and they can easily bolt on to whatever system they've got and keep rolling. So what I probably would suggest is look at probably some existing practices where they tend to be a bit more progressive. I guess if they've got a server, that's a pretty good indication they might not be as progressive. That's the first tip. Run. No, to be fair, I mean, if you're a young practitioner, the senior practitioners want to know you. They want you on their side. And they can bring something as long as they've got an open mind. But you do find that senior practitioners from time to time, the odd one, aren't as progressive. Look, I'll be out there. I'm 56, 56. Yeah, 56. I'm probably the most progressive 56-year-old. I've still got friends that are still using spreadsheets, or some that are even using spreadsheets of major accountants. So don't judge a book by its cover. So find somebody who's a visionary. Find somebody who's a progressive thinker in terms of IT adaptation. That's probably the first thing. Back to jockeys, not the horse. Then look at their vision of what they're actually doing and say, yeah, look, we think the vision is that where we should have shared back office with like-minded, practitioners. Then look at okay, what is the vision? What is the business model? How's it going to work? Unless I said like a tenant practitioner arrangement, which I think is the future. I don't care what anybody tells me. That's what the courts are saying. So get over it. Stop reinventing the wheel and trying to fit a square peg in a round hole. Yeah, if you want to go and get an employee practitioner, yeah, do that. But you'll transition from employee to entrepreneur, is what I call them. So we
Love,
have a director's
love
path.
your ideas. They all fit in. And that's how they retain people, as in,
Mm,
yeah, like from employers, like, crap, my employer's making so much profit from me when I build up. I'm gonna
yeah,
leave. So so
correct.
so you need some kind of scalable model.
Mm. And what this does, and this is what we do with practitioners, and in fact we did a group called Geraldton Medical Group many years ago, and they went from 3 practitioners and no special funding in Geraldton to being the BRW fastest 100,
Yeah.
from 3 to 30 practitioners, with a multi-million-dollar turnover. And I'd actually never met the client; it was all done remotely, and got invited to the awards and got a fair bit of kudos for it. And people said, "Well, how do you do it?" This is, if you have a vision, people will come. If you show it's progressive, and then it actually allows people to one day be an employee, maybe a shareholder of the back end, where it's not so risky, and you don't have to sit there and come up with lots of money, and you can give them equity and a stake, so they've got some skin in the game. And so they're not just eating when they kill; they can actually earn while they sleep, and they can attract their friends. It basically self generates that succession planning and that attraction, and I think that's probably where the future is. And that model's been there for years. It's just people have never had the right business models and the right legal and tax structures, and they're just doing piecemeal fixes to fix things and saying, well, that's what everybody else does, without going, but it can be and has been done better. And I mean, that's what we do for our clients anyway, and that's probably why they come to us in the first instance, is that we're seeing the whole life cycle of not only the practice but the practitioners, and saying, look, you can stay an employee all you want, or if you want to become that solopreneur, you can become that. Or if you want to be a solopreneur and own part of the infrastructure that supports all solopreneurs, you can do that. So there's 3 levels of entry, including when you exit, you can sell it with
Yeah.
a 30% rate of return.
So there's many different ways of scaling in terms of borrowing,
Mm,
franchising it, which has been
correct.
successful, interestingly, in physio.
Yes, correct.
Yep.
It
Not,
does work.
it does work, doesn't it? What other options do people have to scale?
I
Sounds
I I
great.
think
Yep.
yeah, I think that, I mean, that's probably the safest one from a medico legal and taxation point of view. I'm going to be honest. I think the franchises, I think they work, but I don't think I think they're under court tested at the moment. I
Really?
think,
Okay.
oh yeah. So I'm not a big fan of it. I don't think the way what I see out there, I think it's just another, dare I say,
You can say it.
it's
Go.
a, it's a you're sitting on a tax time bomb.
Really? Wow. Okay.
Like right now, and you've all been served constructive notice. And if you don't, well, what's he talking about? Well, if your accountant hasn't spoken to you, you probably need a new accountant. But if you just go and Google payroll tax, and then you look at the new income tax rules, you might be in a bit of a rude shock. Okay. So, and these have come out in the last 24 months.
Okay. So this is really recent. And a lot of these.
Yeah. And people have got nicked. And what you have to understand is the government of the day, or probably into the future, I don't depend on how you vote, Labor or Liberal, they love employees because they get their money up front. They don't have to wait 18 months to do the tax return, right? So there's a very into, hey, you know what, if we can make more people employees, particularly, I guess, if you're more Labor leaning, and that sounds cute and cool, it's because they just pay more tax. They don't like generally businesses that are entrepreneur orientated. They love command and control. But legally, you can set up these structures where you can have your cake and eat it without being in a sham arrangement. And these have been all legally and tax tested. So I see, look, physios aren't dumb, allied health workers aren't dumb. You guys, are very smart people in Australia. I'm just a dumb accountant. Your ATAR score had to be a lot higher. You didn't study this hard to basically sit there and become a wage slave.
A waste.
All right, you didn't, and you're going to fight that, and you're going to fight your independence because you're saying that's why I did this stuff for. This sucks. So nobody likes being told how to do things, and I think this is why this works probably better, the solopreneur environment, because it just allows people to have, their cake and eat it, and the laws are, interesting enough, are validating that. So whether you have a
Very
choice or not about, you know, you are going to be you're going to have to choose. I don't think the subcontracting thing's working at
okay.
all, and I wouldn't be doing it. And so you're going to be forced to choose not 3 options, but 2. Be a tenant practitioner, right, which we call tenant doctor for trademark reasons. We've had to. It's the only way we could keep it, and that includes allied health. Or you're going to be an employee. And I don't think that shade of grey in the middle is going. I mean, BHP's in trouble for all this stuff, right? There's a lot of big companies where people are what I call Friday employees, and they become Monday contractors, right? And nothing's really changed. And they've gone to court. The high courts have said their piece. The employers that have got these deemed employee-like contractor arrangements have smashed that to pieces. And now they're saying, no, you've got to really choose, and you better have the right systems, the right process. And this is why we have this program called Doctor's Pay Calculator, because we've been doing it for the last 30 years this way, where you do tick all those boxes so you can eat well and sleep well and not have to worry about, oh, gee, I didn't have the right letterhead. Oh, I didn't have the right bank account, the right name. Oh, didn't have the right website. And wow, at least now my BAS is a mirror image of the service entity's BAS or the administration entity's BAS, and it doesn't sort of have what I call inconsistent things. And they're doing that. They're doing AI and data matching of both state and federal, contractor data. And they're seeing what's going on the contractor's tax return, and then they're looking at what's going on in what's going on in the administration entity, and boom, they're going, well, hang on, these numbers don't make sense. There's no consistency. And suddenly they're saying, well, hang on, that practitioner now owes us, 10%. So a lot of practitioners might be on let's say a 60-40 split, right? So can you imagine, you're a practitioner, you're paying 40% plus GST, right? Which is, 10% of that. And let's say that's $4. It's a $100 bill, that you're billing a patient. That GST of $4 because the service fee of 40%. Suddenly, that $4, they're going to go back and say, hey, but you're not a genuine business. You're a sham. And suddenly they're going to say, well, pay back that refund, double the penalties from the time you first started working here.
Okay.
That's what the real problem is. So we've looked at, let's say, in general practice, and we've done our numbers, and it comes up to about $500,000 per full-time equivalent practitioner.
It's a major issue if you
Slightly. And now that they've got this whole payroll tax thing with the data, and where your data is now being shared to the federal tax office, and this is where the issues really start to become a bit awkward if you can't answer the question with a straight face. Suddenly the tax office says, well, how come you didn't pay 11.5% super for those subcontractors?
Yeah, I've heard that one. I've
Yeah.
heard it.
And then there's that question. And next minute you're just sitting there, you just can't lie, man. I mean, you got to keep a straight face. And oh, well, she told me, the accountant told me, but well, you never really spoke.
Yeah.
You know,
Okay. That's
that's
really interesting.
yeah.
So just for advice out there, I mean, a lot of physios find it difficult to see, if they Google what's the average income of a physio, it's like 90, 100K or whatever. And they feel it's so low because they got high ATA scores, as you said, thinking that they'll be doctors and like, what? I'm entitled to more.
Yeah.
I can see here, can you help shed light on them that they can actually earn more, as you earlier said, than a GP working for someone?
Yeah. Oh,
Uh,
I
and I'm saying, like, give them the inspiration that, yeah,
yeah.
with these
I,
new structures, they can do a lot better. Yep.
well, they can, but there are, look, a lot of it's your own attitude. I mean, if you don't want to work the hours, you don't expect anything. There's nobody self-entitled, and you and I are, especially, are not. I mean, you actually first want to be a physio first thing, and you want to be really good at your job, and the money you make is a result of what you do. Okay, no app's going to change that. Okay, it's a very personal relationship you have with your patient. So they either trust you, or you don't. So my first rule of thumb is, if people don't trust you and you don't have the evidence to back what you're doing, and look, mind you, I haven't come across a bad physio in my life. They're all excellent at what they do. They're very professional. There's a lot the rest could learn from them, right? And I guess that's part of that whole feeling, well, I'm not number one like the doctors are in the system. And I'm sorry, there is that turf war and that hierarchy you don't take for granted, and which is not a bad thing. It's a good thing where, and this is where I've seen some amazing models where GPs actually refer patients to their clinics. And yeah, I'm easily seeing, clinicians are making, 300-400 an hour easily. And what you're doing is saying, well, I've got a service that I can develop, make 300-400 an hour. I've got to have certain teams or whatever, but a percentage of that gross is what you're really negotiating. You're going to always have to leave something on the table to grow the business.
Yeah.
And you can only do that with scale by pulling in resources and having other like-minded practitioners. Now, if you want to have work-life balance, guess what? If you want to work part-time, you better find someone else that wants to work part-time, and you better sync your school holiday diaries, or find some, and I think this is where people lose a lot of money, because, they go part-time and they could earn that money, but they've got full-time overheads. Okay. And then suddenly they basically are underwater. So look, it doesn't surprise me if you're coming away clear 230 net, as a seasoned practitioner. That's not impossible. And I'm not talking Sydney, I'm just talking here in Adelaide, at a
Mm.
low cost place. Um, and and people are, physios have an ongoing relationship, a therapeutic relationship, which kind of gives them a bit more of a, I hate saying it's less tick and flicky. It's
Duty, care, or
yeah, care, and it's a lot more physical, which basically there's a lot more value there, and people tend to pay for value. Do you know what I mean? And I think that anything you can do, and this is where apps and all these things are becoming really, really important. That the patient walks away, and this is my vision, is that patient will walk away from your clinic, and then they can see on their phone out, oh, this is what I've had done, and their records are all on there. And they know, okay, well, I've come in 3 times, I've got to come in another 4, and this is my improvement, right? People they like to look at, how much money they make, and I can give you an example. I can share a screen if you want, just to give you a sense of how people feel. Everything has to be tangible. You have to have a tangible experience. Let me see if I can just share you my screen and give you a bit of a feel for what I mean. And I found this particularly with medicos, and it's not because anybody's greedy, but we have this thing called the doctor's pay calculator, right? I'll just go to the practitioners section, and I've been doing this for years. But once you actually show somebody, oh, this is how much money you're making, going up and down, you've now got some sort of context, real time, 24/7 on your palm, and you go, right, well, I didn't do well this month, but maybe I did well then, but next month I'm going to have to do more, and you feel more in control. And you feel like this information is reliable, so it motivates you. Now, I don't care what anybody says, but certainly money motivates people. Not for the reasons of greed, but I've got to make bank because I've got to meet the shopping or whatever, or I want to go on that holiday. That once you create a sense of self accountability in the patient's mind, or in this case, in our client's mind, that's one less argument you have. When somebody says, "Oh, I can't afford your service fee," okay, well, hang on, you can. I mean, you're billing, 30,000 a month, right? It stops that stupid argument what you can't do, and you start working on what you can do. Now, you might want to be more efficient, and you don't want to pay a higher service fee. You can then ask more useful and relevant questions about, well, where is that money and that resource going into? What tools are we using? Do we need so many stuff? Can we use a better stack? It starts a point of inquiry, because look, at the end of the day, you want to be a great clinician, but you want to be paid, and you want to be paid well. Okay.
absolutely. Whether you like it or not, I mean, that's life, isn't it? And it's getting more expensive.
Yeah, and you don't want to feel like, nobody wants to feel like they're ripping off anybody. People want to be ethical, but
Yeah.
to actually run a quality practice, you have to make bank. You've got to pay off the loans. You've got to pay for the plant and equipment and the premises and the staff and all the education, which, there are other hidden costs that you don't necessarily see. The starting point is, what is your gross turnover? Do you know what I mean? How frequent is it? I'm getting a bit tired of people saying, well, I'm getting paid less, but you do less work. So proportionally, you're actually being quite well. I mean, I had an argument actually with a Canberra doctor. They said, well, she complains she wants to get paid more. I said, well, why does she want to get paid more? She goes, well, she feels she's getting paid less. Well, she's still making what, $2,000 a day, and it's not like she's getting paid less. She just works once a month. Well, that's why she's making less. And I think, just to kind of stop everybody feeling like they're being hard done by, I think acting with facts and evidence, both financial evidence and clinical evidence, is kind of what keeps everybody, make it open and transparent. I think that makes things a little bit easier, so we can start focusing. It's not on the money, which is, this is a result of what you do, but it's how you do what you do. It's what makes a difference. It's what governance, what processes do you have? What sort of learning and feedback loops do you have to basically scale your practice? And sadly, like it or not, this sort of information is what triggers the conversation, right? Because this is saying to you, this is your dashboard on your car, we're hitting those. We're kind of, we can see where we're going, and we're going to hit our KPIs, or we're not going to hit it. This triggers those other questions, which become quite useful, and it's not something people should fear. So we kind of, the problem with people with financial data at the moment, particularly, I'm finding with all practitioners and practitioners, they can't rely on the data they're getting out of their practice management systems. They're not tax
Yeah.
certified,
Anyway,
and this is what kind of creates the confusion. And I guess this is what this calculator does. It's based on proper service agreements. It's based on a tenant doctor model. It is actually something you say, yeah, this is what I'm going to put on my tax return, and sign off by chartered accountants, lawyers, and tax department. So when they get it, it's not going to be challenged. All of this stuff is really important, that the basics are right before you start arguing all the other stuff, right? I mean, people always say to me, what comes first, the lawyer or the accountant? And I said, it's always the accountant. The accountant's going to tell you whether you can afford the lawyer. The accountant's going to be the last person who says, listen, you can't afford the light bill. So they're going to be there in the beginning, the end, a good one will be. And the numbers don't lie. And whenever you're making any decisions about whatever you're doing, you've got to start with some basic information that everybody's on the same page. And this becomes a good communication tool. Now, this can be easily emulated into the clinical setting, with patients, with graphs and stuff, and keeping it simple.
this is fantastic, David. I might implement this at my clinic, actually, and then we can look into how we can work together to get
Sure.
this right.
Absolutely.
Because
Yeah.
as I said, we're more than just a scribe. We want to help clinics grow at scale,
Mm-hmm. Mm-hmm.
put through
Absolutely.
more money and more profits, right?
Yeah. Well, you've got to do it legally and ethically, and this is what's happened to the doctors, which is why you're getting blowback. These are all the national headings. This is not me making it up and trying to sell a calculator here. The calculators come as a result of these headings.
Yeah.
And I did it privately for my clients, but we've had to make it public and even let other accountants get involved in it because we've got too much work coming through. But what's happening now for us accountants, just so you know what's really going on, we got a heat on us. This is 5th, 7th of January. We have to dob in our clients. We have to dob in each other if we see that the numbers aren't adding up and that the information is being bank reconciled, and we're not doing this. So I don't really care what anybody tells me, right? It's the tax department. I'm just the messenger. You have to get your systems right. And if you don't, I can tell you, it only takes one tax order and that can wipe you out. And I'm dealing with those sorts of matters with some new clients where just poor advice, poor implementation. It doesn't matter how fantastic all these other programs are. This is the one that's going to really set you back. And so really what's happening is, you need to have proper bank reconciliation process, and this is done terribly in this country. There's too many software companies that say, in fact, when you press them and you ask them, oh, is this an accounting system? No, it's a data collection system. I said, yeah, but you're billing my patient GST. How do you know it's right? Oh, it's got nothing to do with it. It's up to what your accountant says. And people go, well, did you ask your accountant? No, well, my accountant doesn't know what the program is, doesn't even know how the program works. And everybody's played what's called the assumption game. And because of the absence of an audit, everybody thinks it's right. And then when you get hit with the audit, there's a problem, which is the reason why we've got actually this problem with payroll tax and income tax in Australia, because everybody's assumed somebody else is on top of it. Oh, the practice manager's smart, she's on it. Oh, the accountant's smart's on it. Oh, my accountant's the top 100 accounting firm. Nah, I don't care. The ones that went down was $1 billion company, listed company called Primary Healthcare over this sort of stuff.
Yeah.
Now, if they can't get it right, and private equity can't get it right, because don't forget, this is affecting all the big listed companies, and all the small ones are affected. Everybody's getting swept up. We've gone through a certification process saying, look, you know what? You're going to have to make sure your lawyers are on the same page. Even the lawyers are getting it wrong. 60% of general practices here in South Australia had a payroll tax problem. They all admitted to last year. That means 100% of their accountants got it wrong. That's 60%. And they use big and small law firms, accounting firms. We've been through and passed audits, right? But we went and did it the hard way, the little bit more expensive way. But you set it up properly, and you set and you forget, and you don't have to go back and reinvent the wheel. And this is probably where apps and smart apps become quite important. And we've got other programs coming in where it'll link up patient records to, other health and allied health records that will spin from this, where we're looking at what are called international healthcare. We set up a thing called an International Healthcare Standards and Ethics Board. It's a non-for-profit where that data actually does get some degree of AI review. So when it's being presented both to the patient and the practitioner, this is way down the track here now. If I sort of tell you how this is probably going to play out, Because look, government also is interested in data. They want to know whether you're giving value for money. Practitioners want to know, well, is this peer reviewed data that I'm looking at, and is the information is correct? And this is where I see how the healthcare industry evolve. And don't forget, I'm an accountant by trade. I'm not a corporate. I don't own practices. I have no interest in it. We're just sitting here saying, here are some key tools that you probably need to be aware of, that you probably don't, and you don't have healthcare peer-reviewed healthcare standards locally or nationally or even internationally. I know because I went to Parliament and I tested it out, and it's actually true. And it starts with the doctors. So if the doctors haven't got it, I'm not sure what everybody else is doing it. And that's because a lot of information is not being collected in a relevant and useful and meaningful and comparable way to each other. So the information and clinical data sets are very, very disparate. They're not up to date with the latest standards. Some of them are conflicted. And as a consequence, that's having a problem with the delivery of safe and efficient and effective healthcare services. And this is what has happened through my journey after my car accident many years ago, having 9 operations and a lot of physiotherapy. I started to realize everybody's got a different opinion about the same thing, and remarkably different depending on what sort of, dare I say, clinical bias that they have. The orthopedic surgeon will say, yeah, your knee needs to come out. You know, physio might say it needs probably a bit more physiotherapy treatment, and maybe a psychiatrist will say, well, you're mad and you've got pain issues. That, you know, pain management therapy in your mind might take the pain away. Now, they're all probably right, but to what degree, and to what degree does everybody talk to each other? This is where the medical and the healthcare records and having some form of centralization that carries with the patients probably the only way, like Xero, will move forward. So then there is some sort of longitudinal and comprehensive and contextualized data repository that stays with the patient, because you're all good at what you do, but without having that other information all available in one spot, we could all be missing something that's pretty important and relevant. So that's kind of my view. I've probably got that totally wrong, but I've looked at the aviation and the accounting industry and looked at what they're doing really well. And we do have global standards, and there is a reason why there is a global financial market for that reason. What gets me is that there's total absence of that in the medical and healthcare space. And I went to Parliament and they all agreed, including the insurers, the AMA. I'm on the federal Hansard on record, but nobody's doing a lot about it. Now, this is where AI technology, and these software programs, if they're being programmed and prompted correctly, you used to have an army of people you needed. You don't need that anymore. You can get proper clinical citations off your mobile phone in a heartbeat if you can upload the data and put it in a way that's kind of going to be easy for these software programs to review and process, and then keep that data and build from that database. So, and that's exciting, I think, for everyone. And I don't think it's a threat. I think it just means that you'll sleep better and you feel that you're providing really comprehensive care, and the patients are going to have a great time with it because they'll have an app saying, yep, everything's on track. I mean, we have a program called The Price of Human Life, and what we're doing is tracking people's health outcomes in financial terms, so people can go, oh, right, okay, I'm actually doing well. Oh, it's going slightly red, like a profit and loss statement. Maybe I need to see some allied health or see a doctor, ask them better questions, and it just prompts them. It's not there to tell them what's right or wrong. It's just to prompt them to they need to maybe go back. It's a bit like, I don't know, the fuel gauge or the oil meter in the car just hitting red or orange. It's enough to nudge them back into the healthcare system. So, and that can be remotely managed. It doesn't have to be something that, and I think patient self-management tools, more and more that's coming into play. But until you get the basic structure and standardization of healthcare information, from collection to making it comparable, useful, relevant, not it's verifiable and there's no material errors, I think the industry as a collective continues to struggle, not only here in Australia, but around the world. But that's also the opportunity. And I see a huge opportunity for everyone, particularly starting from Australia, to kick that forward in leaps and bounds, certainly with new AI technology that we see. Sorry, I've gone on a bit there, but hopefully that gives you a bit of a.
All right. No, really good insights there. I will try to summarize this and get it into a blog post as well for those who don't want to watch the
Sure.
listen to your voice or my voice. And also, uh, if they want to reach out to you, what's the best way?
Oh, well, I mean, they can click there and click on this. I can go to Doctor's Pay or Service Fee Calculator and just click on this Get Faster Help Online, that type of stuff. It's pretty easy. I do
Okay.
have a website called Health and Life. Hopefully this is going to work for me. And I should come up, but I use Perplexity, by the way, which you should all use. It's a great tool if you're trying to do research and stuff. You can even research my name to get my background. But there you go. That's my website there, Health and Life. And you can get a bit of a feel for who we are and what we do and all that other stuff that we do there.
All right.
But
Thanks, David.
there you
Yeah,
go.
sounds good.
All the
So
best.
health and life and servicefeecalculator.com.au.
Yep.
I think David's on LinkedIn too, if you want to
Yep.
follow.
And I'm also on LinkedIn there. You can find me on LinkedIn there. It's not too
Um,
hard. And all you do is you can call us or make an appointment by contacting us, and we can just set up an online meeting and go from there. There you
awesome.
go.
So yeah,
Sweet.
I'll chat to David offline again. We're
Yep.
still seeing how we can work together around
Sure.
these type of ideas. So thanks for your time and catch up soon.
It's a pleasure, my friend. You take care. All the best.
Thank you, David.
All of them.